Hello. So we're here today to discuss two case-based discussions on two good cases. So I'm currently with Salome, who is a physician associate, and she's kindly gonna talk to me about a couple of cases, and then we will go over, we will basically review it and go from there. Okay. So, okay then. So if you can just tell me the first case. So the first case is abdominal pain, and the second case is dizziness. Okay. So if you just let me know,
Sure.
you go first with the tummy pain. So tell me about it.
Sure. So this is a 63-year-old female with a background of hypothyroidism that presented to me with initially intermittent abdominal pain over the previous 2 months. She described it as burning and that it was worse after foods, and she was also slightly constipated, a bit of reflux and nausea. So I told her, let's bring you in, let's examine your stomach.
Very good.
So I brought her in probably about 4 days later, and this time her pain was more constant. She was belching a lot. She started vomiting after each meal and drink, and she attended A&E 1 day prior to seeing me. Because of the symptoms and how severe it become. They done an abdominal x-ray to rule out any bowel obstruction, and they advised that it was normal, and essentially it was basically the constipation that has been giving her those symptoms.
Okay, so severely constipated, acid reflux, vomiting, keep going.
Yeah. So A&E, they gave her suppository and lactulose, but that didn't help, and so she presented to me despite having those things, and she had not opened her bowels since. So she also, I spoke to her daughter over the phone, who told me that she's lost a significant amount of weight, and I think I went back in the consult from 2020 till now. She's lost about 10 kilos in weight. Her appetite was significantly reduced as well. So she had no night sweats, no melena, rectal bleeding, no hematemesis, no post-menopausal bleeding, chest pain or shortness of breath. So on examination, general examination, she was very distressed. She was unable to sit still, was belching throughout the consultation. Her abdomen was soft, but it was generally quite tender. There was no guarding or rebound tenderness at that point. I felt a small lump on the right upper side, just beneath the rib cage, roughly the size of a 50p coin. It was very tender, and maybe circular. I would say maybe the size of a ping pong ball, I would say. But bowel sounds were active. Blood pressure was raised at 158/97. But heart rate, pulse, and temperature, they were all within the normal range. And then sort of my differentials at that point was, my top diagnosis was mainly the constipation, but I was also worried about cholecystitis, or even based on how severe her symptoms was and how long it's been ongoing, I was thinking, could it be cancerous, especially with, she had some cancer red flags. And I think at that point I just needed a second opinion, really, because I wasn't too sure whether she needs to go to hospital now, whether something needs to be done now, or whether it can wait for further investigations.
So you got me involved, didn't you?
Yes. So that's when I came, and I got you.
And I just remember examining, and there was no temperature. There was, I think there was passing lots of urine as well, and there was like general tenderness all over. I couldn't feel an obvious lump, but the point was there was tenderness all over, and she was in a lot of pain. She was constipated. So what was our management plan?
So You asked me to do a urine dip, which I'd done, which came back normal.
So no urine infection.
Yeah, no urine infection. And then we prescribed her a phosphate enema.
Yeah, very good.
And then I sort of recommended lansoprazole just to help her with the reflux symptoms that she's been getting.
Right.
And then you reminded me just to safety net her and say if she, after using the phosphate enema, if she hasn't opened her bowels, then she'll need to go to A&E straight away.
Go to A&E again. But previously the abdominal X-ray had ruled out bowel obstruction from the previous A&E thing. And I didn't think at the time there was bowel obstruction, but basically fecal compaction.
Yeah, compaction. And then I think just based on how severe her symptoms was and the cancer red flags, I was originally, I think I was going to do an ultrasound scan.
Okay.
But then I think when I was going through the direct access one, because I was worried about cancer, I found that she fit the criteria for a CT scan to rule out pancreatic cancer.
Great.
So that's when, then I sent off the
So
2-week weight CT.
So you ordered an urgent CT abdomen?
Yeah.
Okay,
Yeah, because I was worried about her, and it just...
is there any other tests you ordered as the management plan?
Yes, so what else did I did blood tests.
Yeah. So what did you order on the blood tests?
I believe I'd done a full blood count. I also did a calcium, serum free light chain, LFTs,
okay,
and the thyroid as well.
Right.
Yeah.
Okay.
And then that came back. I think another doctor picked up the results from those.
Right. So the results went to another doctor. I think it was Dr. Metwali.
Yeah.
And then he, I think he did a phone call. Was that right?
So what happened originally was that I think I spoke to you first.
Right.
Because I was contacted by her because she wanted some painkillers.
Right, okay.
And then I think I didn't know what to do because the NSAID give reflux or can irritate the bowel, and then also the cocodamol can cause constipation. I think at that point you told me that there's nothing really much that we can give. The phosphate enema would help.
Yeah, and I think there was a delay in giving it as well, wasn't there? Because the pharmacy was quite slow,
Yeah, they were slow as well. And then I think I contacted Dr. Mitwali about it as well.
Okay.
And then he requested for her to come in the next day because he himself wanted to rule out bowel obstruction.
Yeah, okay.
And then he picked up her blood test results.
Yeah. Okay. So let's now just move on to the results of the CT scan and then the blood test results. So what was the CT scan? I've got here showed basically it showed thickened gallbladder wall.
Yeah.
It showed cholecystitis. It also showed some arthritis in the hip and spine, and mild chronic diverticular disease, and a tiny fibroid of 30 millimeters. So there's quite a lot going on.
Yeah.
But the relevant bit for her pain was for me, it was the thickened gallbladder and the inflamed gallbladder. And the blood test, what was the interesting thing that came back about the blood test?
So the blood test shows that she had raised calcium,
Yes.
a raised white cell count,
Okay.
and also I think it was a raised T4 as well.
So the TSH was low and the T4 was up.
Was high,
she was basically still hyperthyroid.
Yeah.
She also had high calcium, and there was a raised white count. Okay.
Yeah.
So, okay then. So, right. So that's and I think Dr. Metwali also reviewed, and her pain had got a lot better after her bowels were emptied.
Yeah.
And he referred on to the gastroenterologist, and I think he wanted to repeat the blood tests. I think that's how he managed it. Okay then. So that's an interesting story.
Yeah.
So what sort of issues are raised from this case that you wanted that made it difficult, for instance?
Yeah, I think it was just mainly the severity of her symptoms, and then deciding what can I do for, like, whether something needs to be done now urgently, like go to A&E, or whether I can just manage her symptoms now and like leave time to investigate the underlying cause.
Yeah.
And then also, it's just, I guess it was mainly just the severity of her symptoms. And maybe because I'm still fairly junior, I guess I didn't want to miss out anything, and I didn't want her to.
No, you did a good
over.
job. I thought you seeked help appropriately, and it was great that you did that CT scan to check the tummy, because I've been GPing for over 10 years now, and I haven't been allowed to order a CT abdomen, but now we can. So it's not all that, and it was useful this time.
Yeah.
Okay. So is there anything else that it made it difficult for you, this case, do you think?
I think it was mainly just the decision making part, and yeah, I think it was mainly the decision making part and the severity of her symptoms, and then I also, there was just, I felt like there was too many decisions that needed to be made at that point, and I felt like it was a bit up, like over my head a little bit. And
it was a difficult case, basically, and it made me, it was hard for me as well. I mean, the main thing is to think of red flags and rule out sort of severe surgical cases like bowel obstruction, and that was but the day before she had a normal abdominal X-ray and was sent home with trying. I don't quite understand why they didn't clear out her bowels, but there we go. But it was back to us, and when I examined, I didn't think there was any obvious bowel obstruction. Okay, so how would you manage it from now on? So what's the ongoing issues here that need to be addressed, that haven't been addressed, do you think?
With this lady?
Yeah. There's a few things that probably need tidying up, I think.
I mean, maybe since we found that she was still hyperthyroid.
Yes, hyperthyroid. Okay, so she's still hyperthyroid. So what's your what's the kind of typical symptoms of hyperthyroid normally on someone?
Hyperthyroid, if I remember correctly, tremor, is it a heat intolerance?
Yeah, very good.
Sort of losing weight, like unintentionally. Diarrhea?
Yes, that's right. Yeah.
And excessive sweating, palpitations. I mean, there could be a lot of.
So there's that going on in the background, and looking at the notes, the endocrine doctor, I think a few weeks prior, was happy to keep on the carbimazole at 10 milligrams. And at the time, looking at the notes, the TSH was suppressed, but the T4 was normal. So he said, well, just carry on with carbimazole 10 milligrams. But the blood test that we did after our test showed that the TSH was still suppressed, I think at 0.01, but the T4 was raised. So that means she's gone overactive. And that can that can explain theoretically weight loss. It can explain also it can actually cause high calcium as well. That's just a small point. So going forward, how would you get the thyroid better if the person's on 10 milligrams of carbimazole? How would you rectify that?
I guess you would increase them.
Yeah, very good. Very good. Yeah, so I would increase it to 15 milligrams once a day, and repeat the thyroid in a couple of months. I think the endocrine doctor is on the case with that.
Okay, fine. So would we do that ourselves, or because she's already under endocrine?
I think we would do it ourselves.
Okay.
So that's the first bit. Okay, is there anything else on the blood test that needs sorting, do you think, that wasn't sorted?
I mean, the raised calcium, but
Yeah,
if you're saying that that's caused by hyperthyroidism...
it could be, but it could well be something else as well,
Yeah.
because we've got weight loss, we've got tummy pain, we've got reflux. So, so basically, I mean, for treatment of high calcium, the main thing is to just encourage lots of fluids. Yeah, and I've learned that when it's above 3, you then ring medical reg and try and have some help on call.
Okay.
So that's how I would manage it. Well, not just, but that's some bit of it. So that's the second point. So we need to work out why the calcium is high. So there's weight loss going on, which could be related to thyroid, but it could be a GI abdominal cancer. So with that in mind, with Dr. Magdi referring to gastroenterologists for gallstone disease, is there anything that you would change now with the management? With the, because it's, if you think of the red flags, how would you change your management?
As in, but the thing is, because we've done the CT scan and they've essentially, I think that's ruled out any type of cancer.
No, not necessarily.
No?
So what can CT scan of the abdomen can miss certain cancers? Do you know what that could be?
I'm assuming bone.
No. So the main thing is gastric cancer. It actually doesn't show up sometimes on CT scans. So she basically needs an urgent OGD.
Oh, okay.
Definitely.
Okay.
So basically, what I'm thinking is to refer under the 2-week wait actually, to get her quicker sorted. So that's what we can do as well.
Okay.
And then the other issue is there's another issue as well on the blood tests that need tidying up.
The white cell.
Yes.
Yeah.
So the white cell count was quite up, wasn't it?
Yeah.
It was neutrophil. I think it was something like 14 or 13.
Yeah, I think so. Yeah.
So the next question is, why has she got a raised white cell count? So I'm just thinking how we can manage that as well, because with inflammation of the gallbladder, cholecystitis, is it just inflammation raising the white blood count, or is there an infection going on in her gallbladder that's not getting treated? She didn't have a fever, but so repeating the blood test will be useful to see if the white cell's gone down. But for me, I would bring her up soon to see how her tummy pain is. So that's so I think we just do a phone call after this and deal with that.
Yeah, sure. And so if her tummy pain is better,
right? So if she's not getting right-sided pain, if it was just related, for instance, to constipation, then I wouldn't. Well, we can talk about it once. It depends.
Yeah, depending on her response. Sure.
Okay, so there's that bit going on. All right then. There was one other thing that made it quite difficult to diagnose gallstone disease. What was that on examination, do you think?
Maybe because she was just very tender throughout.
Yeah.
And then the Murphy sign is the sort of sign you look for sort of like a inflamed gallbladder. But then also I feel like she didn't have much of a temperature. I don't know. I think it's very confusing. So I think we weren't able to examine properly. Well, I personally was unable to examine properly because she was in a lot of pain when I was pressing. And then I guess I didn't even attempt to do the Murphy's test because I thought she's already in a lot of pain.
Well, you felt the right side, remember, and you thought there was a lump there.
Yeah.
But you it was painful, wasn't it?
Yeah.
yeah, I mean, for me, it wasn't typical gallbladder pain, because typical gallstone pain is intermittent pain on the right side going to the back.
Yeah.
But her pain was sort of central, kind of all going round, perhaps worse in the right upper quadrant, but still, it wasn't typical, and that's what kind of made it quite difficult to actually diagnose gallstones straight away. So I think because basically there's multiple problems come into play here. You've got the constipation, which can cause central intermittent tummy pain, and then you've got the gallstone getting inflamed, and then you've got the high calcium going on in the thyroid, overactive thyroid, and then you've even got a bit of acid reflux as well. So that's why it wasn't clear cut and actually quite difficult to pinpoint. So that's just my thoughts. So there we go.
I agree.
So there we go. So how do you think you went? What went well for you in this case, do you think?
Went well. I mean, I'm happy that I brought her in for an examination. I feel like over the phone when I initially spoke to her, it just didn't sound so bad.
Yeah.
But I think what I've learned now from this in particular is anyone with abdominal pain, bring them in to examine their stomach.
Yeah, it can be difficult to do it over the phone, basically. So
and I think I guess my history taking was good as well. The fact that I brought you in, I think I was having that debate in my head along with other debates whether is there a doctor available for me to grab? Is this a suitable patient for me to grab to grab a doctor to go over with me? So I was I'm glad I made that decision to bring you in, because it definitely was over my head.
And I thought you did well with ordering that CT abdomen as well. That was really good, because that's basically made things a lot more clearer for us and me. So how do you think you could have done things better, looking back, do you think?
Looking back, I'm not really too sure. I think I was definitely quite nervous during that consult, and I think it's when I look back, I think I could have just taken some time to gather my thoughts, think about sort of like my plan, but I just felt that my brain was working too fast at the moment in time, and it definitely does happen to me a lot when I'm worried about a patient, and so I don't really have much clarity of thought. I also feel that the way I've done the initial speaking to her over the phone, then bringing her in, I feel like it sometimes messes up the history taking, because I've already asked those questions. What more do I need to ask? Can I remember what I asked before? And I feel like that sometimes it's when it's one full consult, you have all the information there in one go, whereas when it's bits and bobs, you tend to, I don't know, it tends to be a bit confusing for me.
I mean, I think reviewing it was a complicated case. There were many problems going on, but I think overall you did a good job for your stage in your career. I think it was great how you did the CT scan, and it was great you seeked help appropriately, and you were safe. So that was good. Okay, let's move on to the second case now, something a lot more simpler, sort of.
I think this one...
So this one's about dizziness, okay? So if you can just tell me about her.
This lady, she's a 28-year-old lady.
Yes.
Presenting with intermittent dizziness ongoing for the past month.
Okay.
She said she's had 4 to 5 episodes. One episode was the room was spinning, and the other episodes were more she was spinning. It lasts from minutes to 1 hour. She said it comes on suddenly, she has no warning signs, and it's random and it's unrelated to posture, so she could be standing or sitting and it still happens.
Okay.
It's not triggered by any head movements. So it started around the time she restarted her combined oral contraceptive pill, and she was wondering whether that could be a trigger.
Right.
Her dizziness episodes, they are associated with double vision and I believe it was right-sided ear throbbing.
Okay.
And then sort of after those episodes that she gets, she has difficulty concentrating for about 4 to 5 minutes. She's also said that headaches have been more frequent recently.
Okay.
When she closes her eyes and looks down, that can relieve her symptoms. But other than that, she had no preceding upper respiratory tract infection, no other ear symptoms like hearing loss, discharge, tinnitus, no nausea, vomiting, no recent head injury or trauma, and no chest pain, palpitations, shortness of breath, doesn't suffer from anxiety or depression, and there's not been any personal family history of any ear problems. She's otherwise well within herself. She's eating and drinking okay, 3 meals a day. She reports that she doesn't drink much water, and she's a non-smoker and occasionally drinks. So I done an ear examination, which was unremarkable. Her cranial nerve exam, so cranial nerves 2 to 12, they were normal. And Bromberg's test was negative. Heel to toe, her gait was normal. Heel to toe was normal as well. In terms of what my differentials were at that point, I honestly had no idea. The only thing I could think of is, could it be due to maybe dehydration? She's not drinking enough water. Could she be a bit anemic? But when I think about it, anemia wouldn't just have sort of random episodes like that. Or maybe an atypical presentation of Meniere's. I don't know. So that was my differentials. And in terms of what I done next, I think I just decided, let's do some blood tests to rule out anything like anemia and anything else that at that moment in time I couldn't really think of. So I just done a routine sort of blood test for her. Yeah. So that's it. The reason why I chose this case in particular, I just think it just didn't fit with anything in particular for me. It didn't really fit much with Meniere's. It didn't fit much with the other vertigo sort of
causes.
Yeah. And so I was just kind of left, didn't really know what to say to her. And that's why I chose this one.
Yeah, it can be difficult, vertigo. Or dizziness. You're not the only one to think that dizziness can be difficult to get a diagnosis out of it. Okay, so so you had the issues of uncertainty with the diagnosis. Is there any other issues that you're worried about, or anything else that you think this could be, that you feel that you haven't covered? Anything? I mean, the story was good. You asked pretty well most of the questions.
Not necessarily really. It was mainly just sort of coming up with a diagnosis, and so either that or have I asked her enough questions for me to be able to get a diagnosis. So I think that was sort of what I was thinking about, whether there's something that I've missed, whether it could be related to the contraceptive pill. I think I told her at that point that I didn't think so, because she's been on it and then she stopped and then she restarted.
I wouldn't say it's a contraceptive.
So I think I was honest with her. I mean, I told her I'm not too sure what it was. And maybe just hope that maybe something the blood test might.
Right. Yeah, we haven't got them.
We haven't.
Back yet.
Yeah, we haven't.
Okay then. So how do you think it went? What do you think went well for you in this case?
What I think went well. I think, I don't know. I guess my history taking went well.
Yeah, yeah. I think that's right. Yeah, the history was good.
I think my examinations were okay. There definitely is more that I could have done. Maybe the one to rule out BPPV, the one with the, I think it's the head impulse test.
You kind of mention it in your story. You kind of ruled it out actually in your initial story. You said that it didn't only come on. It didn't really come on with head movements. It was kind of came on at rest as well.
Yeah.
So I think we can exclude BPV.
Okay.
It's just a few seconds. The vertigo, and it's due to a head movement.
Yeah. Okay.
Okay. So I think you did well with getting the story right, and you thought of pretty well most of the common causes. I think I'm just thinking how you think you could have done better as well. Anything you can think of there?
I'm not too sure, to be honest. Maybe you can tell me.
Okay. All right then. So I think the first thing with dizziness is the key question. I don't know if you've been taught this or routinely done, as to what differentiate between vertigo and lightheadedness and something else. Yeah. So what I say is, so what do you mean by the word dizziness?
Yeah.
So you just say, so I go, so what do you mean by the word dizziness? Do you mean a rotating, spinning thing?
Yeah.
Which is like where it's unbalanced outside or coming from within. So that's vertigo, yeah. And then the other one is a sort of lightheadedness. Do you feel? Do you mean dizziness where it's kind of like you feel a bit lightheaded, slight visual disturbances when you, for instance, when you stand up, or something else?
Okay.
Yeah, because the causes of vertigo and the causes of lightheadedness, dizziness, vague thing, are different, and it's really important right from the start to try and work out which it is.
Yeah.
But from your story, we'll go down the vertigo pathway.
Yeah.
All right. So that's just a way of just organising your brain a bit. But so I think the headache history needs a bit more focusing. So, for instance, so you need to ask about the quality of the headache. Is it at the front? Is it at the side? Is it throbbing? Is it intermittent? Is there any nausea or vomiting linked with it? Dislike of bright light and noise. I think up to about 30 or 40% of migraines are actually linked with vertigo.
Oh, okay.
So where I'm going with this one is it could be migraine that this is doing. With vertigo migraine, you can annoyingly just get the vertigo and not the headache, so it doesn't have to be linked. But I think if you just sort of go a bit more into that and just see if it is a possibility of migraine. But I like the way you did, you looked in the ears and there was no obvious infection. You also, I think in your story, ask about upper respiratory tract infection before the dizziness happens, so it's unlikely to be a viral labyrinthitis. I mean, the main causes of vertigo are BPV, labyrinthitis, Meniere's, migraine. There wasn't any drugs. I think you didn't mention any drugs, but I don't think she's on any drugs.
No, it was just the oral contraception, I think she was on.
So going forward, with that in mind, how would you manage her now?
So maybe, like you said, explore the headaches a bit more detail.
So you can wait for the blood tests and go from there.
Going forward,
It could just be. Thing with anxiety and psychological causes, it's more kind of lightheadedness, vague kind of story. They can't really pinpoint what they mean by dizziness. It's all a bit vague. But you did well with mentioning that there was no obvious stress going on.
Yeah.
So yeah, that's my thoughts really. So that's where it is really.
Yeah, that sounds good. I think I'll do that. Yeah.
So there we go. Okay. Well, so what we'll do is we'll contact those two people, and then we will work out how we go from there. Okay.
Sure.
But great.
All right.
Well done.
Yeah, thank you, Dr. Moore.
Okay then. Great. Let's go with that plan. Thanks.
Sure.